is confusing that there's two Melissa Bryant, so we'll have to.
I just texted
Hi,
her to change
everybody.
it.
This is Brett Copeland with the Veterans Healthcare Policy Institute. Thank you for joining us today. We are getting everyone into our Zoom room. We will start the program here in just another minute while we get everybody in, but thank you for joining us, and we'll talk to you very soon. All right, again, welcome. I'm Brett Copeland. I'm Executive Director of the Veterans Healthcare Policy Institute. Thank you for joining us today for our one of our series of forums. This one is on disparities of care for veterans of color. We're very thankful to, as being a 501c3 nonprofit, we're thankful to all of our generous donors who have donated their time and money to make this program possible. In part, we want to give a special thank to Craig Newmark Philanthropies, who has been very generous in a grant that he gave earlier this year. The way that the show is going to play out today, we're going to have a discussion up front for the first half hour, and then we'll be answering questions, or our panelists will be answering questions in the second half. We've long known that people of color do not have the same access to healthcare, nor are they treated equitably by healthcare providers as white Americans are. Studies show us that non-VA providers are commonly unfamiliar with the unique needs of veterans and ill-equipped to address the fallout of military service. During the coronavirus pandemic, we've seen how people of color have been hit the hardest. Non-white Americans are contracting, being hospitalized, and dying of COVID-19 at far greater numbers than white Americans. One of the statistics that really struck me in just the last couple of days is roughly 1 in every 1,000 Black Americans has died from COVID-19. This also, of course, includes Black, Latino, American Indians, are all vastly overrepresented in COVID deaths. Today, we want to talk about where people of color collide with veteran status, because we know that veterans are at similar high risk to contract COVID-19 because of their many chronic co-occurring conditions that have resulted from their service in the US military. We also want to learn about how reducing disparities in care for veterans when we compare the VA's response to the private sector. So we've gathered this incredible group of panelists today that include Melissa Bryant, who is a veterans advocate and formerly of the director of the National Legislative Division of the American Legion, and was the chief policy officer at IAVA. Lindsay Church is co-founder and executive director of Minority Veterans of America. Suzanne Gordon is one of our VHPI senior policy analysts. She's also a journalist and author of 2 books on veterans, Wounds of War and The Battle for Veterans Healthcare. And finally, we've got Harold Kudler, who is the adjunct associate professor of psychiatry and behavioral sciences at Duke University. He's also a former national mental health policy lead in the Department of Veterans Affairs Central Office. So Suzanne, I'd like to start with you. With COVID-19, we've seen so many stories and studies about how people of color are being hit the hardest. Would you tell us a little bit about the disparities in care that existed before the pandemic, and what has changed since coronavirus has hit at the VA and in the private sector?
Right. So I want to thank everybody for being here. I'm honored to be with so many wonderful people who are doing such incredible work. So essentially, with the pandemic has really shown a spotlight on all the problems in the American healthcare system. And of course, because this insidious virus attacks people who have what we call in healthcare comorbidities or other healthcare conditions, and as well as people who are older, if you have any kind of underlying chronic condition, obesity, diabetes, congestive heart failure, etc., you will be more at risk for hospitalization and death from this COVID-19 virus. And also, even if you survive hospitalization, we're finding out that there are more long-term chronic health problems. We actually don't know how long-term they will be, but serious problems that are just becoming clear as we learn more about this novel virus. And of course, because veterans, by virtue of the fact that most of the VA's patients are older, poor, and sicker, and also sicker because they're older and poor, they are at higher risk for hospitalization and death from COVID-19. And I would make the argument, I know we're supposed to be nonpartisan, but that this administration's policies around COVID-19 denial and failure to really articulate the important articulate and reinforce and model this public health message, that this is actually an attack on people who are old, poor, and of color. And there's also obviously overlap in that. What we've seen that's really interesting in the VA, when we looked at, and there just came out, a paper just came out on healthcare disparities. They looked at 6 million patients and disparities in COVID-19. And they found that, and they looked at testing positive and 30-day mortality, death after 30 days. They found that minority veterans and people of color had higher rates of positive COVID tests, which is to be expected because these veterans are much higher risk for getting this infection, but there were no disparities in fatalities. And so that means that what you see in the private sector healthcare system is that there are not only disparities in infection, but also disparities in fatalities with people of color dying, and also older people, right, particularly in nursing homes, dying in way higher numbers. This isn't true in the VA. One of the main things that is really interesting in the VA is that for those veterans of color who are in nursing homes and long-term care facilities, the VA instituted the right COVID policies to protect these residents immediately. And we're not seeing that in private sector nursing homes where people of color, you know, who are residents in private sector nursing homes are dying vastly out in huge numbers. And also, interestingly, in state veterans homes, there is way more deaths and infections because some of them have been outsourced to private sector for-profit providers. What's really interesting to me in trying to look into these studies, particularly the study that came out of the Connecticut VA healthcare system, is that the Trump administration will not let you find out about this. I've been studying VA healthcare for almost 10 years now, and certainly under the Obama administration, there were problems accessing good information and getting the VA to be responsive, but nothing like there is today under the Trump administration. And I called the public affairs office at the Connecticut VA, and I wanted to talk and get more information and background information about this study, because all of you know that these studies that appear in these journals are very compacted, and often some of the most interesting things are left out. And when you talk to the researchers, you find out some really interesting, even more interesting details. And they will not let you, at least wouldn't let me, talk to the researchers. Now, I'm someone who, you know, had total access to the VA under the Obama administration. I could talk to anybody I wanted, for good or bad. And basically, the PAO in the Connecticut healthcare system didn't even know about this study that was done by researchers in the Connecticut VA healthcare system. And for 2 weeks, I tried to talk to the researchers. I put in a request to talk to the researchers on background, right? I mean, not for attribution. And that was stonewalled. And so basically, here's this really important news that people need to know about the VA. And these researchers, I mean, this is a public healthcare system, and information is supposed to be public, right? I mean, it's paid for by the taxpayers, but this administration will not let us learn from these important lessons. We need to know from the VA why are there no disparities? And of course, then I had to talk to other people around these people. And I think Harold can talk to this, and so can Lindsay and Melissa. But one of the reasons why we have better outcomes is because the VA provides more coordinated care to folks. So it's a different kind of care that they get. And also because, as the American Journal of Public Health wrote in an issue in 2014 entirely dedicated to healthcare disparities and inequities in the VA. They're, for all their problems, of which there are many, and there's way more that can be done, and I think we're going to discuss all the things that need to be done. The VA is really the only healthcare system in the United States that is interested in even approaching and studying these kinds of problems within that healthcare system. And we need to know what they've done that's right, what needs to be done to improve, and also use this information to get best practices out to the private sector healthcare system. And really that's being stonewalled. That kind of scientific data is being stonewalled.
Lindsay, in your work with Minority Veterans of America, how have these disparities in care impacted you and the veterans that you engage with? And how have you seen that change after the pandemic hit?
Thanks for your question, and thanks for having me. So first and foremost, we see one, COVID exposed like the cracks and the equity gaps that exist prior to the pandemic, and not just exposed them, but magnified them for the world to see. Many of the equity gaps probably, I think in my own personal opinion, maybe never would have been addressed had the pandemic not exposed them and showed the public, the American public, and our policymakers that we can't ignore that there were great equity gaps that were existent before the fact. So in addition, we've seen a rise in need from our community. Largely, we've seen that veterans of color have limited access and socioeconomic resources to be able to access digital technology necessary to utilize the access to care that we've, under the pandemic, used to broaden accessibility, such as like most mental health services have gone to a virtual environment, which has been great for folks that had technology. For folks that didn't have technology before, it doesn't necessarily help them. In addition, you look at under-resourced communities, you see that there are great disparities in the access and the type of internet that's available. So if you look at tribal and indigenous lands, you're looking at people that don't actually have access and likely haven't had access for a very long time. But now the only lifeline that they have is the mental health or the access to technology, or using technology to access your provider. Now they don't have that access and aren't likely to get it anytime soon. So people are actually starting to pay attention to that, but that this is a disparity that existed long before. In addition, we're seeing disparities in the types of work and the wages that are earned through it. So we're seeing a greater amount of exposure through folks who are and continue to be our essential workers. They're more likely to be out there on the front lines working and being exposed on a regular basis. So you're seeing more folks who are exposed to the virus. In addition, anecdotally, our organization has it's called the COVID-19 Relief Fund. We've had about 1,000 applications since we opened it in June. 50% of those have been from veterans of color, from Black and African American veterans specifically. Only 18% have actually been from white veterans. So we are seeing a greater need from our veterans of color since the pandemic happened, especially because we focus on food insecurity, transportation insecurity, and utility assistance and things that folks don't really have the ability to pay right now.
And Melissa, when you were with IAVA and the American Legion, what role did race play in discussions about policy, or specifically healthcare policy? Did race or minority status ever come up?
Yes, it did. How do I answer this delicately? So let's first start with, obviously you're serving two entirely different populations when you're looking at the American Legion versus Iraq and Afghanistan Veterans of America. The post 9/11 generation, which while I was there, I always was cognizant of pointing out to folks, is an entire statistical generation at this point. 20 years of war, 20 years of a generation where we have we have post 9/11 veterans now who are in their 60s, who are 50s, who have retired because they were there at the tail end of 9/11 and jumping into the wards. And so I think understanding the nuance of what is needed for a generation with that broad span, and what is needed also for a generation that was increasingly more diverse, is at the forefront of the post 9/11 generations and the post 9/11 veteran service organizations and those that have come since then, like Minority Veterans of America. Not to to have anything against the big six or traditional VSOs. Hi to all my friends who are on, from all of them here. Some of my former staff from the Legion I see here. it's just that it's a problem that they hadn't really thought about in the same way. It's no secret, and I will not go into any details of the of where race fell into some of the traditional VSOs, and particularly within my own personal experience at the American Legion, there's conversations around comorbidities. We recognize, I fully agree with everything that Suzanne and Lindsay started off with in talking about how it was very readily apparent how this pandemic had disproportionately impacted Black and Brown communities especially. And what do those comorbidities then mean when you're looking at veterans and looking at our care within the pandemic? And so you're looking at two different approaches. You have one traditional VSO to where that was maybe not at the forefront of their mind in looking at it from race. Maybe they're looking at it from purely from age, and that's because the age and the membership of those dues paying members who belong to traditional VSOs skew older, whiter, male. You're going to see that reflected in the policy discussions. You're going to see that even though there's more on women, there's more on minorities, and I certainly, as National Legislative Director there, fought to bring more of that into the policy discussion. There's only been so much you can do with what your membership says. And that's one of the constant struggles of the VSOs, especially the resolution-based ones. Whereas at IAVA, race and factoring in race into healthcare outcomes, not really a problem. We could go down a litany of saints of other issues that may come up where post 9/11 VSOs can be a bit myopic sometimes. But when it comes to race, I think that that's really a challenge within the veteran service landscape because personally for me, being in the middle of this sea change and watching our policy positions take hold within 2020 and the context of 2020 within the racial reckoning that we're in right now, on top of a global pandemic, it's hard to ignore how race factors into these things. It's hard to ignore finally what many of us have been talking about for years. I'm an alumnus of Howard School of Law, Hampton University. I mean, there are a lot of things that I've known from Reconstruction that people are just now reading Atlantic articles about. And for 20 years, I thought I was taking crazy pills. That people didn't understand the direct correlations to poor health outcomes and how that relates to poverty, how it relates to intersectionality, the double burden of Black women. When we're looking at childcare, seeking care at the VA, someone finally not asking me where my sponsor is when I show up at the VA. I could go on for days as I'm seeing head nods across our panelists, but it really is a layered question in answering that of what I saw within the racial disparities and how does that fit within policy discussions. I think 2020, when we do the postmortem of 2020, we're going to see this year as a blessing and a curse of where the blessing in this, yes, the curse is that 220,000 American lives have been lost. And many of them have been from my community, from the Black and Brown community. And it's incredibly disheartening. I think that the lesson learned coming out of this is that we have been here, we serve. Many of you have heard me speak before. I always talk about being a third generation combat veteran. My grandfather killed in actual World War II. My father serving in Vietnam for 20 years, 27 years after that. And I say it because I really feel as though we need to reinforce that we've been serving since the beginning of the armed forces, and yet we've not necessarily received the same level of care, particularly from the VA. We have a need for more data out of the Office of Health Equity. I mean, I want to steal too much of Harold's thunder because I know he's probably going to pull into some of these data points, but we need to really drill down more into why are we, for example, dying of COVID at higher and disproportionate rates outside of, looking at it from the perspective of comorbidity factors like diabetes, obesity, things like that have particularly plagued the Black community. These are things that I would hope that a more holistic conversation will come out of this reckoning within 2020. And it won't just be post 9/11 groups or woke liberal groups or anyone else who sees it. It's just science. And I hope that the VA can follow suit with that. And the VSOs will also, their membership will morph them towards caring more within policy that impacts the whole.
And just as a
Sorry,
reminder,
no, that was a mouthful.
Oh, no, thank you. Just as a reminder to everybody, if you have a question that you want to ask, throw it into the chat now, and we will try and get to it in our second half. To Harold, we know that equitable access to care is critical for physical health for individuals. but what is the impact of mental health treatment for veterans of color, especially when it comes to PTSD, suicide prevention, and behavioral health?
Right. Well, first of all, thank you for having me. And this is a great conversation. I'm really glad to be able to be a part of it. I have shared links to a summary and then to the actual study that Suzanne was speaking about in the chat room. So if anybody wants to grab them off the chat, they can. And I want to make a comment about this. So VA found that veterans showed the same racial disparities in catching COVID, but not the same in dying of COVID. And I want to point out that although this was done in Connecticut, one of the authors is actually out of a London program, and it reflects 5.8 million veterans in VA care. Within that group, about 250,000 were tested for COVID. The reason I'm pointing this out is that the VA is the largest health system in America, one of the largest in the world. The VA collects data on class, race, socioeconomic status in a way that's uniform across its entire system. Nobody else does that. Even if you went today to the CDC data, and I'll admit I went there this morning to see what was what, there's a disclaimer there that, we say what's going on in states, we say what's going on in counties, we don't identify racial groups the same way. So you can't say at this point in time that an Hispanic person is an Hispanic person is an Hispanic person. We faced the same problem when VA was trying to say how many veterans die a day of suicide. It took years to get clean data from all 50 states that could reliably say who was a veteran, who died by suicide, and who were they. And only the VA can do that in America. I'm very proud of the VA, but and I'm sure that'll come across several times. But I want to be clear that we can all do better. But the story about health disparities, which is real, and I can entirely agree with what Melissa and Lindsay were saying. This is all a curse and a blessing. The seams of our system have been stretched to the point of almost breaking and sometimes completely breaking. And now we see those seams and we're going to get to spend years fixing them, or miracle reweaving them maybe as a culture. So we got that going. To go back to your question. Oh, and I want to just throw in also, so why aren't veterans dying? If they're getting the disease at the same rate, and by the way, these other complicating health conditions don't seem to account for deaths, the change in mortality. Urbanity does. If you live in an urban area, you are much more likely to catch COVID. That speaks to the fact of being close and the need for social distancing and masks and things like that. But why aren't veterans dying? I'd like to believe it's because we provide access to care. And that gets to something we've learned about PTSD. A lot of people will say about the Black community that they don't trust healthcare systems and go back to Tuskegee. And I'm sure you can go back to a lot of things even before Tuskegee, why they wouldn't want to do that. However, what we found when we look, say, at PTSD, finally getting to your question, Brett, is that Black veterans, Native American veterans, Hispanic veterans, all had higher rates of PTSD. If you look at the National Vietnam Veteran Readjustment Study and then the follow-up Matsunaga study, which looked at American Indians and Native Hawaiians and Pacific Islanders. But in terms of did they access care, the fact was race didn't determine who accessed care. What determined who accessed care was the severity of symptoms. This to me also suggests that when you have an open system like the VA that says, if you're a veteran and you have a problem, we're going to try to take care of you. If you'll come, people will come. And I believe that if they come, they're more likely to live. The same thing is true about suicide in VA, that this idea that 20 American veterans, frankly, it included military members too. I think 2.5 of the 20 who die a day are statistically military members still in the military. They're not veterans yet. But whatever you want to say, if it's 20 a day, which is easier to remember, and 14 of them aren't in our system, we found that the 6 who died, that people who actually use VA were less likely to die by suicide. I would like to be able to tell you, I know that that's because we deliver such great suicide prevention service. I often wonder, though, if people who choose to get care are just less likely to die of suicide, that these are people who are trying to take care of themselves and have the wherewithal to get that care. Lots of things determine whether you get that care. Where do you live? What's your transportation? Probably the biggest obstacle to care is transportation. Do you have a job that you can't leave? A lot of people in lower socioeconomic class are essential workers and they can't get the time off to get an appointment, or they can't get babysitting, or, you know, et cetera, et cetera. So there are a lot of factors here, but I really do believe that the VA, because it provides care for this entire population, and people know it's there, and they actually, many of them trust it. And our rates have gone up since 2014, but people trust us. I think they access care, they get better, they do well. Just to say, there are lots of things to say about what was found in the Vietnam War. We know more about that than we know about any other cohort. It's now one of our largest cohorts in VA. It was for a short while the very largest. Now, not quite. The post-Vietnam is getting bigger. But there were these interesting findings, for instance, that Black Vietnam veterans had a higher rate of PTSD. So did Hispanic veterans in the original Vietnam Veteran Readjustment Study. But when you controlled for combat exposure, it turned out Black veterans had a higher rate of combat exposure. And when you controlled for the rate of combat exposure, Black veterans were no more likely than white. Hispanic veterans were more likely, even when you controlled for that. God alone knows what that is. I've never seen anybody explain that one. And, but it may be a cultural expression. I remember from my days in the emergency room in New Haven, which has a large Hispanic population, that Hispanic people are more likely to tell you their problems than Black or white people. And that may be a factor. And then Native Americans. And you know, I don't think any health system in America, with the exception of those created by tribes for tribes, are really prepared to take good care of Native Americans, because Native Americans, kind of like me, need to tell the whole story. And our systems aren't created to allow them time and space to do that. And so they get short shrift. So I don't think we have any good, reliable information about Native Americans, except to say that where, you know, there are large Native American populations, they also share that high burden of COVID infection. And in North Carolina, at least months ago, it seems to have washed out some now, they were much more likely to die. This is also a moving target. The statistics in CDC are changing month by month of who gets this and who dies by it. I'll stop talking there.
Suzanne, going back to you, it's something that both Harold and Lindsay have talked about just briefly, but things like housing, employment are so important to getting good care. How, especially with kind of the budget shortfall that state governments are having with unemployment benefits, you know, what is the future role of the VA when it comes to that public health model and social determinants of health in providing care to veterans?
Right. Thank you so much for asking. Thank you. I'm so excited about this conversation. We could probably go on for days as opposed to even more hours. I think that it's really important to understand that, and Harold said it really well, you know, in spite of its flaws, and this could be really helped with better funding and better staffing, but in spite of its flaws, the VA is really the only health, well, I would argue the VA is the only healthcare system in the country. I mean, we have a kind of fragmented medical intervention system, which those of us who are not veterans experience the terrible care. I have quote unquote Cadillac care. And one of the things that in my 10 years of following VA patients around, I was really impressed by is I always describe VA when it works at its best as concierge care for poor people. I'll never get the kind of care with my Cadillac plan that veterans will get when the VA is at its best. I mean, it just doesn't exist in the private sector. You have to be your own advocate. But I think that the VA, you know, one of the things the VA does is it deals with issues like employment, like housing, legal issues, the Veterans Justice Program, et cetera. homelessness. I mean, when I was doing Wounds of War, I spent days with, you know, a VA social worker trying to track down homeless people in San Francisco. And I'm telling you, Sutter Healthcare does not want homeless people in its waiting rooms, black, brown, purple, white, whatever their color, they don't want them. And the VA, but I think that this employment, the issue of employment is really critical. And as both Lindsay and Melissa and Harold have pointed out, I mean, we are seeing a massive gaps in you know, the sort of wonders of the gig economy don't look so wonderful anymore, the precarious jobs, you know, working in Amazon warehouses and so forth. I mean, these are the first jobs to go. I mean, you can't work remote from home in an Amazon warehouse, right? And so we've seen veteran unemployment go from 3% to 12% because veterans of color, poor veterans, people who haven't, you know, veterans with OTH and bad paper discharges, general discharges, who haven't been able to access the GI Bill or the help that is needed to get them through college and community college and university. These people have low wage churn jobs, and they've been just churned out, you know. And I think what this means now, and I really hope veteran service organizations are listening, because I'm not sure they've listened hard enough, not just on the issue of race, but on the issue of class, because which intersect, obviously. And these people they are losing their jobs. Most of those jobs didn't have good healthcare, but if they had healthcare, they're losing their healthcare because of our crazy healthcare, non-healthcare system, non-health, non-care, non-system. And they're losing their jobs. That means they lose any healthcare insurance they had. So the VA, these people are going to be suddenly needing the VA more than ever before. And they are not going to get help from the private sector because the private sector is collapsing. 1 in 4, I believe it is, primary care providers are going out of business. 20 to 40% of American hospitals are in trouble. So if folks think that privatization or quote unquote choice outside the VA is going to work, think again and look at the facts. And so we need to be prepared to how are we going to help? You know, how is the VA going to accommodate 12% more veterans by virtue of the fact that they've lost their job? Many of them are people of color and women in low income position and LGBTQ, et cetera, Native Americans, you name it. And they're going to need the VA more than ever before. And we need to think about how we're going to accommodate them, because there's going to be need for more money, to hire more staff, to do more infrastructure repair, et cetera, et cetera. And I hope that, you know, that is a takeaway message for all
Melissa,
of us.
so Melissa, the groups that Suzanne just was talking about, I mean, all of those unemployed veterans, that doesn't include veterans who are currently ineligible for VA care because of their discharge status or priority group. Mm-hmm. What, in your opinion, do you think can be done to make sure that those folks are not left behind?
I mean, outside of flushing our state and local governments with money, I mean, they need to be able to put that toward programs that we know have proof of concept that work for each locality, because we talked about urbanity versus living in rural areas. And you do have Black folk in rural areas. There's still all of us down south who weren't a part of the Great Migration up north. And so when you're looking at these disenfranchised communities, I think that really is key, is looking at what's happening at the local level and or at least being able to facilitate scaling at the local level to see what works in certain areas and what does not work in certain areas. Getting folks to work is absolutely a priority. As you mentioned, Brett, when you're looking at trying to capture those who are not enrolled in VA, those veterans we're not capturing within the unemployment numbers that come out from BLS each month, I'm sure the number is way above what we're actually seeing represented. Again, we know that there's a dearth of data that speaks to intersectionality, that speaks to various crosstabs when you're looking at down to the state level, even down to the city level. Look, as a state, I'm originally from Pennsylvania, Philadelphia and Pittsburgh and Alabama in between. There's no one state solution for Pennsylvania veterans. And I say this, to the point of a lot of what's already come up in commentary before. When I think of PTSD from Vietnam era, and I think of those veterans, I think of my father who goes to the Philadelphia VA. And just to answer your question, Dr. Kudler, I mean, I think really cultural competency when you're talking about mental health is absolutely the reason. I can tell you that traditionally African-American families, Black families, you push it down, very much the same as WASPy families, so to speak. And that is, you suppress bad news and bad feelings, and we don't talk about things even to the detriment of, knowing your own family lineage, sometimes. It's why we're all on ancestry.com now. And so that's a part of the Black tradition in the household, as opposed to the Latina, tradition of, yes, we're going to share everything. Everyone's a part of it. And it's multi-generational as a default. And so understanding that starts with, to get to your question, Brett, of how do we, solve this problem? We need decision makers in the room who understand these things. And I know this is a segue into other things we're going to talk about, but within the policy discussion, it can't just be tokenism. Look, it's not lost on me that I'm the one woman of color sitting here right now. Let's be frank. If we're going to address these issues, you need more persons of color who can speak to their lived experience, their academic experience, the totality of it all, and putting all of that into rooms where policy decisions are being made. And that's what's missing, because you can surmise and you can suppose as much as you can. You can read all of the studies as much as you can, but there's no replacement for that lived experience within the room at the time of making policy decisions and vetting in terms of even thinking, is this something that would work? Not to disrespect anything that's ever come out of VA in terms of, we'll focus on mental health for the time being, or economic opportunity, really anything. I could go across the board of VHA and VADA, but when it comes to, again, those factors, those stressors that lead to worse healthcare outcomes, economic opportunity or lack thereof, financial stressors, things like that, all of that comes in with basically to something past the sniff test, to someone who lives from that community and then says, is this something that would even resonate with others? Because I can tell you of many countless tone deaf policies I've heard that have come out, or outreach programs that have been launched to no avail, to bring in those folks who are not coming into VA. And it's really because they just don't resonate within that community for myriad reasons. And I could give specific examples, but we'd be here all day.
And let's actually move to that for both Lindsay and Melissa. What are some better tactics that VSOs, policymakers, where decisions are made, wherever those decisions happen, how can we bring more veterans of color into the process? So Lindsay, do you want to get started with that?
Yeah, so I think from a perspective of trying to recruit more minority veterans, a lot of people ask this question. It's a very common question. It's a very relevant and pertinent question. And one of the things that I often tell people is that don't focus on recruitment, focus on retention. Change your organizational culture, change and shift the way that things are done in your organization in order to be able to better support those that do come through the door. Because one of the things, like I've seen, much to Melissa's point, you can have 1 million outreach campaigns, but if they don't resonate and there's not a culture that supports them when they come in the door, then it doesn't actually matter. You can have the best marketing campaign in the world, but if it doesn't actually align with your organization's mission, vision, values, and the way that you operate, it doesn't actually help anybody, and it won't actually keep people in your organization. So you don't have to recruit so much if you actually retain the people that you're serving to begin with. So I often tell people, work on the inclusion of your organization, shift the culture, work on changing policies, focus on the highest level of your organizations and bringing in, if you want to get those folks in that policy discussion, you need to look at revising and revamping your entire board of directors, your entire directorship staff, all of your higher level leadership. If you're truly committed to this and you really want to make a difference and you want to change your organization for not just the moment, but for the rest of your organization's history, you have to be willing to make bold moves, and those bold moves require sacrifice on some people's parts. Oftentimes you'll see a board that's largely or predominantly white right now, and most people know that your board is 100% white or it's 95% white with that one person that's intersectional and is like a woman of color. Well, if you're on that board, step down and make place, change the way that and take those bold moves if you're going to actually retain those folks. So for me, it's all about VSOs can do better to recruit by not focusing on recruitment, by actually focusing on retention, focus on inclusion, focus on changing and shifting your culture so that you can better serve those organizations or serve those people that come into your doors.
Back to you, Melissa, same question. What can we do from a VSO standpoint, or, where decisions are made, and change it?
Well, Lindsay just spoke to it 100% spot on. Full disclosure, she actually asked me to be on her board. So yes, and which I gladly accepted. And so but that is it. It really is, in a nutshell. What I hope comes out of 2020 is that we are no longer tokenized, and that inclusion really becomes a part of the discussion. And when I say tokenized, in the sense that talking diversity and inclusion was a PowerPoint, especially for those of us who came from DoD like I did. It's a PowerPoint. It's a quarterly training. It's, all right, we have this Black person on the panel. I often say I feel like a village person. Like, we've got a cop, we got an Indian, we've got, and I'm just filling in for village person number, X within X panel for the day. That's tokenism. That's not inclusion. That's not inclusivity. And I hope that 2020 at least will bring about real conversations in that regard, so that you do start inculcating that messaging from the very top. It's business operations, it's substantive policy development, it's tooth to tail, it's more than just HR, and making sure that you're HR compliant. And that, I think, is where the difference of where we started on conversations about race and mental health and health outcomes overall, to where we are now. I think we're having more inclusive discussions that are at least getting down to the nitty gritty of what are the challenges, what are the needs, doing true needs assessments and market assessments, and then placing that against the policy solutions that work. So what can VSOs do? Be genuine. Be genuine in your outreach. I've been a part of some recruiting processes that were, I think, very genuine, very well-intentioned, but still a little bit misguided. And I think anyone who's met me knows that I'm not a wallflower. And so, I'll say encourage the non-wallflowers to speak. Encourage, I'm going to be the one who's going to say something. That's just my personality. Whereas I have worked with many a colleague who were smarter, brighter, published authors who sat on the sidelines because they didn't feel empowered. And not everyone's going to have the chutzpah to just come up and speak and speak to what they see. And so what VSOs really need to do, if you really do care about being invested in the totality of our community, two things. One, don't say, well, we're here for all veterans. Stop it. Like, it's 2020. You should know by now that that's not correct. It's tone deaf, and it's not speaking to specific needs. Just stop it. You started with women veterans, now it turned into Black veterans. Now as a Black woman veteran, I'm tired of hearing we all bleed green. We don't. So let's talk about nuance, and let's get comfortable with uncomfortable conversations about disparities in care and why delivery of care is so disparate across various communities. So that's number one. And then number two, foster and mentor. That's what we absolutely have to do within the veteran space, because we're out there, but we've been shunned, or we've been disempowered or discouraged from being a part of the conversation, whether it's through your resolution process for the traditional VSOs, or it's through your policy surveys that you're putting out in places like IAVA, where that's the bread and butter that falls into their policy making. Throughout these processes, you need to be intentional in ensuring representation. And that means outreach, and that means encouragement, and that means hearing some uncomfortable truths that may cause an identity quake within you as leadership. Because just because you've been well-intentioned and you've been thoughtful in what you're doing as a leader, and you said, well, I'm not racist, you still have something to learn. Everyone has something to learn. And if there's any big takeaway that I could say to anyone sitting in a C-suite, that's where you need to focus going forward after 2020, is I need to have my own reckoning with things that may be uncomfortable to recognize. And that's where you may have allowed for implicit bias to come into your decision-making and into your policy positions as a veteran service organization.
So I know that we said we were going to get to questions. I hope that our speakers will stick around for just a few minutes. There are two more questions I want to ask of both Harold and Suzanne, but I ask that you all keep it short so we can get to those questions. Harold, when we're talking about cultural competency, as Melissa just did and Lindsay did, What mechanisms exist within the VA to address those areas? And does that have any kind of parallel that exists in the private sector around cultural competency?
Yeah, I wish I could tell you that VA does a wonderful job of training its new recruits and its students and trainees. We're the largest provider of medical education in the nation. That we do a great job of training people to do this, and we don't. But do you learn in the School of Hard Knocks? Will veterans tell you this stuff? Yes, they will. And in studies that we did in VA and then were replicated independently by RAND, VA clinicians, like DoD clinicians, have a very high level of cultural competence, which is incredibly important in getting these histories at all. Joel Peterson was saying, 3 out of 4 veterans don't trust VA. We can argue which veterans and do and don't, and also trust them for what. But unless you know how to listen, unless you know some good questions to ask, and frankly, unless you can make creative use of your own ignorance, because no 2 veterans have the same history, you're not going to do well with this group. So what really scares me is in the Mission Act, as in choice, but more so in the Mission Act, as we send people out to community providers, this one for that problem, this one for that problem, what the RAND and VA studies show is those community providers have zilch cultural competence, nor do they even recognize there are issues to be dealt with. Those folks are not going to get the same history, and therefore they're not going to discover the problems or be able to treat those problems, nor communicate with us about them. And that's a major concern. Most community providers don't even ask their patients, have you or someone close to you served in the military? And if they did, 1 out of 5 Americans would say yes, but they don't ask, they just ignore it. Likely because they don't know what to do with the answer. So it's a major problem, and something that VA does better than others, and yet we're paying for people to get care in the community. I want them to have access, but access to what?
Suzanne, as Harold was saying, with the VA Mission Act and all of these folks kind of leaving the VA for community providers, is there a way that the VA can ensure that the community care network is ready, and is it really possible?
So I'm going to say something, and I hope people will listen and not take offense, but I think we have to stop using the term community for non-VA providers, because what it suggests is that there's the community out there and the VA is not part of the community. And I think that that's, as someone who's a woman, I'm not a person of color, but I'm a Jew. I'm very, and as a journalist, I'm very sensitive to language. And I think we have to pay a lot of attention to our language. And I'm really disturbed that those who favor VA privatization have constructed this as the community and the VA. The VA is part of the American healthcare landscape, and it's pretty important that folks recognize that it's part of the healthcare system. So I would suggest a change. I don't care what the VA or the privatizers use for this in this language, but I think we need to talk about private sector care and non-VA care, and not the community and the VA. That's really disturbing, because that leaves veterans outside of the community, and I think that's very significant. So I think that what we've learned is that in the private sector and in non-VA care, there is really no interest. It's not just what Harold said, that they know zilch. It's that they also have zilch interest in knowing, in finding this out. And this has been documented in study after study. They are not interested in finding out about veterans' complex problems. And if they're not interested in finding out about white veterans' complex problems, they're definitely not going to be interested. They're not interested in finding out white male veterans' problems. They're not going to be interested in finding out about female veteran of color or female veterans or poor people or whatever. And they document this over and over again. And I think, Brett, I completely lost track of your question. I'm really sorry, but because I
think that you definitely answered it in how VA, and the community are not separate things. So I'd like to move to folks' questions now. If you have a question, please raise your hand and we'll try and get through them, as many as we can. but thank you to our speakers for being so generous with your time thus far. But we'd love to hear from participants on what they're thinking or what they'd like to know more on. Let's see. Does anybody have a question they'd like to ask? Either throw it in the chat or raise your hand. Scrolling through here.
There was
I saw, oh no, I'm sorry, Susie. I just saw one from Larry Johnson that asked about lack of confidentiality in mental health treatment. It's probably a good one for Dr. Kudler to answer.
Oh, I just typed up an answer.
Okay.
I think what he may be referring to is that during the recent wars in Afghanistan and Iraq, it was put in the Congressional Register that if a commanding officer was aware that a deployable service member, maybe a Guard and Reserve member, maybe an active duty person who used the VA under TRICARE, had gotten services to the VA, the commanding officer could request that record and get it from the VA for purposes of determining deployability. But with that exception, and that is a rare occurrence, but it's real. It's not something the VA asked for, but it was imposed on us. With that exception, the VA records are completely confidential. The veteran has to write, put in writing a request that be released, the same as anywhere else.
And if I could just quickly dovetail on that one, we do understand there is distrust. One of the things I talked about on the DOD side of things is question 21 on the SF-86, and just putting on my intel hat very quickly. That's something that's been detrimental for years in asking about mental health treatment, seeking mental health treatment. While we've fought very hard and are winning in destigmatizing seeking mental health treatment, it is still very much a concern for those who work in any clearance related job. Because when you put that on your SF-86, you do have to explain what it's for. You have to explain what it's related to. There's a litany of other things. It brings further scrutiny is the point. And again, when you're talking about diversifying the ranks, from my perspective of sometimes being the only one in the room who looks like me, it's because you can't get through yet another barrier. A security clearance is a huge barrier for a lot of folks. If you've had financial issues, if you have sought mental health treatment at some point throughout your life, those types of things get reported as you're trying to get a job. And when you look at, for example, under the Obama administration, a huge push to recruit Black and brown folk into federal jobs, veterans into veterans preference labeled jobs, that's a barrier if you're going to have issues that will hold you back from obtaining a security clearance. And so, which we know that's federal service is one of the places where Black veterans seek to go after service. So all of these things are interrelated when you're talking financial, economic opportunity, et cetera. It impacts on your mental health, and then vice versa. It feels like a vicious cycle sometimes to be able to escape from for a lot of veterans of color.
From Maureen Elias, whose responsibility should it be to ensure non-VA providers are aware of the specific health needs of veterans' health? Suzanne, do you want to start with this one?
It is the responsibility of Congress to put that in legislation and rules, and it's the responsibility of the private sector non-VA providers to learn that. We are essentially giving them a lot of money and absolutely free of accountability and transparency. And the same is true of responsibility for harm. The VA, if you are harmed from a preventable error or injury, there's a process through which you can go and you get essentially, it's considered a service-connected disability and you get cure forever. If you go to the private sector, you're basically thrown into the malpractice system, and we know how terrible that is. And if the most highly educated, white person on earth can't manage it. And if we think people of color with mental health problems or physical disabilities can manage it, think again. Senator Chester has introduced a bill that would make the VA responsible for the private sector's harm. And I think that's a disaster because that just lets them off the hook completely. They have no incentive to deliver high quality care. So I think that, another thing that we have to think about in this disparities of color issue is that we are going to come out of this COVID thing. If we ever come out of it, it's going to be a disaster, as we know. I mean, it's already a disaster, and it's going to be a worse disaster. And there's going to be a lot of money being, no matter who's, particularly if Biden wins, there's going to be a lot of people coming after, a very small pot of money. And I think we have to think more and more, if we really care about veterans of color and women veterans, we have to think about how we spend this money. And private sector care costs 4 to 7 times more than the VA. And that means that we have to think very carefully about, where we're putting those scarce dollars. And if choosing private sector care when the VA is able and willing to provide that care and could, if we fund it and staff it better, we need to think about the consequences of this kind of constant outsourcing, which we're now seeing more of with the Scott-Hannon Act, which is in our view even worse than mission, and potentially worse than mission.
Harold, do you want to add anything to that about whose responsibility it is? I'm just going to go across our panelists and we'll close after this.
A lot of different groups, especially the American Academy of Nursing, have been pushing Ask the Question for years. And I'm very glad to say that as part of its suicide prevention efforts, SAMHSA and the VA are teamed, and one of them to create new initiatives. And one of them is that every provider in America of any kind needs to ask the question, have you or someone close to you served in the military? If we can get that across the plate, we're going to raise awareness of these vets, and that will lead to people getting used to talking about issues and asking the question.
Thanks. Lindsay?
My personal opinion is that if the onus is on the VA, if they're going to provide funding to the private sector to be able to care for veterans, then they should also hold the private sector to the same standards that it would their own internal providers. I shouldn't, as a veteran, as an LGBTQ veteran, wonder if I'm going to go out into the private sector and be harmed by anti-LGBTQ practices. I feel like if the VA refers me to a provider, which they often do, they should actually be the folks that ensure that my quality of care is going to be continued, at least from VA standards, and into the private sector.
Melissa?
I'll certainly say that, yes, I do believe that VA is responsible because you're the one doling out the money. So therefore, you should have that oversight along with Congress. That said, I would also be careful not to entirely dismiss the community. I'll use air quotes for lack of a alternate term, Suzanne, just to speak to within just to bring it full circle from the beginning of our conversation, we talked about lack of trust within communities of color within VA. It goes back to Tuskegee, it goes back to eugenics, it goes back to a lot of the things that are coming to light now. Again, 2020, when my father went to Tuskegee University, he went to Vietnam in 1968 after doing ROTC there. And so these are things that we carry with us. We carry that with us. Now he receives 100% of his care from the VA, service connected, all of it, loves Philadelphia VA. But that was not always the case. And that's the challenge that we need to do, is we need to borrow, if we're going to use a community and leverage a community. Some of these communities have made inroads with communities of color, with LGBTQ. We can go down the list of where in specialized care, they have been able to crack that code, particularly vis-a-vis mental health. And so there's some things to be learned from them, but they're not being held accountable. And that's where the accountability piece needs to come back in from VA. At the end of the day, VA is not Blue Cross Blue Shield, and you're not pimping them out for, insurance and bringing folks in. I would love to see the same standard of care that I receive at a local clinic in my hometown, where they understand myself, my father, and frankly, they understand a lot of veterans around there, because there is a concentrated bunch in Philadelphia. I would like to see that replicated also in the DC VA as well, because frankly, I don't always receive that same care at the DC VA or other VAs around the country. So the problem is we're not leveraging all of our existing networks as they stand. So we're all accountable within this country, and it's something that we need to ensure that we continue that message. 70% of providers train through VA. That's something that starts way back in med school. So we need to make sure that we're continuing with that and building partnerships that are meaningful, lasting, and substantive.
And I think that's a great point for us to end on today. Whenever, especially through COVID-19, we're having a real reckoning with what the future of the American healthcare system looks like. And I know that from a progressive standpoint, a lot of people are looking overseas for models of care. And whether it is Congress or the VSOs or activists, nobody is looking at the real comparison between private sector care and the VA here as a potential starting point. So all of the topics that we've talked about today, I think fit a lot of different frames in the conversations that we're having more broadly nationally. So thank you, Melissa Bryant, Lindsay Church, Suzanne Gordon, and Harold Kudler for joining us today. And thank all of you. We really have enjoyed putting these forums together to do some deeper dives on specific care as it relates to veterans. And that's only possible because you all keep showing up. We also really appreciate if you haven't been one of our donors before, we would love to have you help us continue this work by visiting veteranspolicy.org. There, not only can you make a quick donation, you can also sign up for our weekly email list and find a link to our YouTube page where this stream will live forever. So thank you again to our panelists and all of you for joining us for this conversation today. We will see you on our next forum on November 12th. It will be our first forum after Election Day, just the day after Veterans Day as well. So we hope you will stay tuned to veteranspolicy.org and our newsletter to learn more about that. Thank you and have a great day.